Hello everyone, welcome to the online platform of Live Guru, and I am Dr. Upasana Regmi, second year resident in psychiatry, and I'll be taking the courses in psychiatry. And let me explain something about psychiatry, and that is, it is not only relevant in our society or social clinical platform, but also in CEE, that is the academics, because it not only takes only small part, but it is allied to the major subjects like medicine, pediatrics, and also the pharmacology, which carries high marks in our exams. So let's discuss psychiatry as per the need of our academics, as well as per our relevance in the society also. So welcome again, and I'll be discussing major topics regarding the psychiatry. Okay, let's start today's discussion. I have the topic of the day, that is antipsychotics. So it is a major topic in this psychiatry, as we have been seeing that we have been prescribing antipsychotics to many of the patients in and around. So let us see what the antipsychotics mean. So these are the class of drugs used to treat psychotic disorder. And what could be the psychotic disorder in which the antipsychotics are used? Let us see the indications. So these are the few indications, as you can see on the screen. First one is the schizophrenia. Another is mania, and then severe depression and delusional disorder, borderline personality disorder, and substance-induced psychotic disorder. Apart from this, there could be some other indications which I haven't mentioned. This could be enough for the appearing in academics or exams. Now moving on, before starting the topic of antipsychotics, we should know how the psychosis is developed in our brain or in our body. So there is a role of monoamine neurotransmitter called dopamine in the development of psychosis. So regarding this, I'd like to say there is one hypothesis called dopaminergic hypothesis. So what it says, that whatever a psychotic patient experiences is due to dysfunction in level of dopamine in our brain. So either there is increased or decreased level, but for psychosis there is always increased level of dopamine. So because of the increased level of dopamine, whatever we experience in the psychotic patient, either those are hallucinations or delusions, it is because of this dopamine level. So since it is increased, we need to decrease the level of dopamine so that we can control those. Now moving on, the dopamine, it should act on some pathways in our brain. So in our brain there are four major dopaminergic pathways, which are as follows. The first one would be the mesolimbic pathway. So here the meso means it starts from the ventral tegmental area in brain to limbic system. Sorry. So it is responsible for the positive symptoms that are hallucinations and delusions in schizophrenia or any other psychotic disorders. Next would be the mesocortical. This pathway also starts from the ventral tegmental area to the prefrontal cortex. So this is responsible for the negative symptoms. So in case of schizophrenia, there is low level of dopamine in mesocortical area. So this gives rise to the negative symptoms, which are alogia, anhedonia, asociality, apathy, and so these are the absence of the normal phenomenon in our brain. Next would be the nigrostriatal pathway. So it starts with the substantia nigra to striatum, and it is responsible for the extrapyramidal symptoms in psychotic disorders. Next would be the tuberoinfundibular pathway. Generally, the dopamine inhibits prolactin secretion. So, in case of schizophrenia, there is increase in dopamine level. So, the prolactin is being inhibited. So this is the major pathways where dopamine acts. Now moving on, let's see the receptors on which the dopamine acts and produces its effects. So there are 5 primary dopamine receptors in our brain, that is D1 to D5, and among that D1 and D2 is the highest, it is found in the highest density among all the mentioned pathways, or as I have earlier mentioned, the 4 major pathways of the dopamine. But clinically, what we are targeting as antipsychotic drugs is the D2 receptor. This is the most clinically relevant receptor for our purpose. So now let's move on to the main topic of today, that is antipsychotics. How we classify it? There is basically 2 types of classification. One is based on the chemical composition, that is composition. It is the first way of classifying antipsychotics, but however it is not that relevant in our context, because we prescribe it as more first generation and second generation. So in first generation we also call it as typical, and second generation we also call it as atypical, based on the types of receptor that they act on. First let's discuss about the first generation. So in first generation it only blocks the D2 receptor present in the brain and all those dopaminergic pathway, because it is not selective to any one of the dopaminergic pathway. So now we can easily appreciate that what happens in different pathways when the antipsychotics act. So first, in the mesolimbic pathway, as we have said that during psychotic episodes there is increased level of dopamine in mesolimbic pathway, which results in the positive symptoms. So when we inhibit this pathway with antipsychotics, we can decrease the positive symptoms. So positive symptoms like hallucinations and delusions are decreased by using this. Next is mesocortical. Here there is already low level of dopamine during the psychotic episodes. which gives rise to negative symptoms. So when we use antipsychotics, it further decreases the dopamine level. So it increases the negative symptoms more than before. Finally, another one is the nigrostriatal pathway. Here, because of the increased level of dopamine, there was probability or risk of developing the extrapyramidal symptoms or dystonia or Parkinson, any dyskinesias. But since we are inhibiting that effect, so the extrapyramidal symptoms will be less. Another one is tuberoinfundibular pathway. Usually the dopamine has inhibitory action to the prolactin, but as we are decreasing the level of dopamine, the prolactin here will increase, giving rise to the following like galactorrhea, gynecomastia and sexual dysfunction. Next, we can also classify the first generation drugs according to the potency. So potency means that what amount of drug or what doses of drug is required to produce that effect. So it can be classified into high potency and low potency first generation drugs. High potency means that is even relatively small doses produce strong antipsychotic effect. So these include haloperidol, flufenazine, trifluperazine, and since they are strongly antipsychotic effect, so they also exert a more extrapyramidal side effects and increased level of hyperprolactinemia. However, on the other side, the low potency drug like chlorpromazine, it requires increased doses to produce the antipsychotic effect, and it is not selective or it easily quickly dissociates from the dopamine receptor. And apart from that, chlorpromazine also acts on the alpha adrenergic receptor. So by inhibiting this, it can cause orthostatic hypotension. Similarly, it can act on the H1 histaminic receptor. So by inhibiting this, antihistaminic effects can be seen like sedation and weight gain. Apart from this, it also acts on cholinergic receptors. So by inhibiting this, they exert the anticholinergic effect like dry mouth, decreased urination, blurring of vision, constipation, and so on. So these are the side effects, because side effects of low potency drugs like chlorpromazine, because it acts apart from the D2 receptor, it acts in the following receptors also. So moving forward, we come to the second generation antipsychotics. So why we call it as second generation? Because it not only acts on D2 receptor but also another group of receptors called serotonin receptors, and mainly the 5-HT2A subtype of the serotonin receptor. So here the second generation drugs binds to the D2 receptor transiently and dissociates very quickly. So the relatively normal dopamine neurotransmission occurs. And we can also see that here the action is more on 5-HT receptors, that is serotonin receptors, than the dopamine receptors. So the extra pyramidal side effects are seen lesser in comparison to first generation. Okay. That's why these are also called the atypical drugs. Now, what are the benefits of choosing atypical drugs or second generation drugs over the first generation? Is that it produces low extrapyramidal symptoms, and unlike the first generation, it improves the negative symptoms also. And regarding cognition also, it improves the cognition by using the second generation over the first generation drug. Now there are some of the examples of second generation drugs. As the name suggests, aripiprazole, clozapine, olanzapine, quetiapine, and risperidone. There are some other drugs which I could name, like ziprasidone, which is also one of the examples of second generation drugs. So I'll be briefly talking about the side effects of these drugs individually, because these are some high yield questions in our academics also, and we can prepare that way. So let's first talk about the clozapine and olanzapine. So apart from exerting its effect on D2 receptor and 5-HT2A receptor, it also acts on 5-HT, that is serotonin, subtype 2C. So it inhibits this receptor and it causes weight gain. Also hyperglycemia. Also dyslipidemia. So overall, these could lead to the metabolic syndrome. So the question could be, what are the drugs which is causing the weight gain? Okay, so by exerting its effect on 5-HT2C, it is giving all this metabolic syndrome. So we can answer either clozapine or olanzapine as per the options mentioned. And if we are asked about the receptor, then we can go for the 5-HT2C receptor. Next is the group of drugs clozapine, olanzapine, and quetiapine. So among these, clozapine and olanzapine is, you have already seen its side effect another way. Now with this, they also act on the H1, that is H1 histaminic receptor. Histaminic. So by inhibiting this, they produce effect, which are sedation and subsequent weight gain. So when you are asked about the antihistaminic receptor, you can answer the sedation and weight gain. Next is clozapine and risperidone. They both also act on alpha-1 adrenergic receptor. By inhibiting this, they will cause orthostatic hypotension. So whenever we prescribe these drugs, we should always ask about these side effects accordingly. Next, risperidone itself. So among all the second generation antipsychotics, this is the drug which strongly binds to D2 receptor. So binding with the D2 receptor, as already told, that it causes the increased extrapyramidal symptoms and also hyperprolactinemia. So if the question is asked, among the second generation drug, which one causes the which one has the increased probability to give the extrapyramidal symptoms, the answer would be risperidone. Now another drug is aripiprazole. It has some uniqueness to its action, because all the drugs, as I have already mentioned, we are talking about antipsychotics, so they are actually antidopaminergic. But this drug is dopamine agonist also. So you can say it as a partial agonist on dopamine receptor. So if someone is taking, question could be, if someone is taking antipsychotic agent for treatment of psychosis and it causes galactorrhea as a side effect, so you want to change the drug. So which drug would you prefer, so that you could cover both psychotic effect also, antipsychotic effect also, and also at the same time you could decrease the galactorrhea? So your answer would be aripiprazole. Why? Because it is the partial agonist, so it covers both. But if you want to give only the dopamine agonist, then bromocriptine could be used, but it would not do anything to its antipsychotic effect. It would not have any antipsychotic effect. So this is about aripiprazole. And next would be clozapine. So clozapine is the important drug. We do not use clozapine in the first line. It is always comes in the second line treatment. So that means after we have tried all the first generation or second generation antipsychotics and the patient does not respond to at least 2 antipsychotics for its adequate doses and duration, then we opt for clozapine. So treatment resistant schizophrenia could be one of the indications for the clozapine use. But clozapine is the efficacious drug over all second generation and first generation antipsychotics, but it it comes with some price. That means the side effects are risky. So apart from all the side effects already discussed, the other side effects for clozapine is, the first severe side effect is agranulocytosis. That means decrease WBC count, mostly the neutrophil count. So we should take care whenever we prescribe clozapine. We should have regular lab investigation for checking the WBC count. Next one would be decreased seizure threshold. That means even in the normal person, if the clozapine is being used without any history of seizure disorder, it could lower the threshold for seizure and patient might seize. So among these two, the question could be like, which one is the dose dependent? The second one, that is seizure, is the dose dependent side effect of the clozapine. That means whenever we increase the dose, we can get this side effect, and if we keep the dose low, then we can prevent this side effect. However, agranulocytosis is dose independent. For seizure, you can say that more than 600 milligram could produce this seizure. Next is, it can also cause carditis. So these are some life-threatening side effects which we should keep in our mind before prescribing. But apart from this, we can also have sialorrhea, that means drooling of saliva, which we also called wet pillow syndrome. And sedation and constipation are one of the side effects which are general side effects. With this, we have come to the end of our discussion for today. Thank you everyone for watching this video, and hope it was useful and precise for your upcoming exam and future. Let's see in the future that we have more discussion topics to come, and we shall meet next time. Thank you. Namaste.